I'll introduce Dr. Saltzburg. She's a board-certified physician specializing in hair restoration and cosmetic medicine procedures for men and women of all skin types. Dr. Saltzburg began her career as a pediatric neurology nurse at the Children's Hospital of Philadelphia before beginning her medical career at PCOM. Dr. Saltzburg is the only graduate to ever have completed a triple degree program as a trainee, obtaining her DO degree while simultaneously working towards her MBA in healthcare administration and a master's in biomedical ethics. She now practices full-time as a hair transplant surgeon and further specializes in the most advanced non-surgical hair restoration, most notably regenerative medicine for hair growth injections. Please help me welcome Dr. Lauren Saltzburg.
Oh, let me put this down here. All right, good afternoon, everybody. Happy Friday from Atlantic City. My name is Dr. Saltzburg. I am a family med physician, board certified, and then I went into hair loss and laser aesthetics and some injectables really from the get-go of residency, kind of fell into my lap right after I graduated from PCOM. So I've been doing this probably since my first year of my residency, and now I'm about 8 years or so out, and I feel like I've been doing it for 40 or 50 years when you do something every day, so now this is all I do. I'm gonna try to, I feel like you've been hearing this every day, every hour, put so much into 1 hour, but I'm gonna do the same darn thing. I'm just gonna kind of put the bulk of what I think is important for the hair loss. If you guys are actively treating hair loss, if you're working them up, or if it's something that you're interested in wanting to get into, that's kind of my goal today. And then just to start dipping people's toes into the world of laser aesthetics and what we kind of do before we're just sending people off to get surgery, things that you're going to start hearing about more from your clients and your patients. So this is just kind of a glimpse into a bit of a different world that's out there. I love it, so I hope you do too. All right, so this is approach, okay? This is just a little picture that we had from my website that shows you my dermatoscope. So when getting into hair loss, okay, and we have two offices. One's right here in Linwood, right next to Atlantic City, and another office up in Center City, Philly. Both are hair restoration centers. So when you're talking about hair loss, if you don't get the right diagnosis, just like everything else we know, you're really going to be lost. So the diagnosis is critical, critical, critical. I mean, once you get past that diagnosis, there's really nice little pathways that we can follow, but you have to get your right diagnosis, and that's why just having that handheld dermatoscope, just like anyone else, any other tool that other specialists are using, that's kind of in my pocket at all times. It's in my bag, I always have it. That allows me to give a nice visualization of the scalp up close. I'm able to calculate how many follicular units are there per square centimeter. You can see a better visualization of the scalp if there's some sort of cicatricial alopecia going on. So this is what we're going to talk about. We really need to think about hair loss as being cicatricial or non-cicatricial, scarring or non-scarring, and then is it genetic or not genetic? Okay, so once you can get those down, all right, why is this important? The anatomy, of course, so we always go back to, because it correlates with the treatment, all right? So when I have a patient come in, I'm putting them on a whole regimen. It's not like I'm just going Rogaine or minoxidil or Propecia. I mean, there's always a mix, and the reason is because each of those different treatment modalities is going to be correlated with the anatomy, whether I'm impacting the anagen phase of the hair cycle, whether I'm impacting the 5-alpha reductase inhibitory mechanism, whether I'm dilating the blood vessel, it could be nutritional. So there's something different, and they're all acting in a different manner. So when my clients, my patients are putting these things together, we have to figure out, all right, what are we doing as far as the hair cycle? How are we impacting this in different ways? Are you going to be compliant? Are you going to even do these treatments? Downtime, all these things are different, but they all come back to the anatomy. All right, so you got to know the life cycle. I mean, this is just basic that we've learned back in M1. All right, so in give or take on an average day, okay, about 85 to 90% of our hairs on our head are in that anagen stage. All right, so we're mostly in the growth phase. Catagen, that's like you're leaving. All right, 1 to 2 weeks you're out, and then you're in the telogen phase. That's where that hair is actually falling out. You see that new dermal papillae is coming up behind it, going to take its place. But that hair, if you suffer from genetic pattern baldness, okay, AJA, what we'll talk about in a second, then that new hair, it's going to come in, but it's going to be miniaturized. It's going to be thinner, it's going to be smaller, and it's going to be shorter. Eventually, it just gets so thin that they don't have any hair there, all right? And once that hair is not going to grow out anymore, then the only thing we have to do is replace it with a transplant. If it's as small as it can possibly be, still in that telogen phase, then we can kind of resurrect it and make it coming thicker, darker, and coarser, but some of the medicines are impacting these stages, okay? So we just talk about alopecia. Let's just make sure we are totally good with scarring versus non-scarring, cicatricial or non-cicatricial, okay? So this is something that I use for my office, so I put it up here today. So non-scarring, all right, that's the one that we're mostly dealt with, okay? Because the scarring alopecias we'll talk about can get pretty tricky, and that's when you're really going to work with derm, because scarring alopecias can really go down a different treatment route. But non-scarring alopecia, all right, simply referred to as alopecia half the time, is hair loss acquired by genes, changes to the hair growth cycle rather than destruction, okay? So it's non-scarring. When we talk about scarring alopecias, I'll show you how our CD8 and our CD4 cells are actually attacking the follicle, leaving fibrotic tissue, and there's no way that the hair is going to be able to go through that, all right? So what are types of the non-scarring? Your typical genetic hair loss, your men and female pattern hair loss, alopecia areata, our autoimmune condition, which sometimes often gets mistaken for a cicatricial because it looks like lichen planopilaris, but it's not. So we'll go through how to make sure you differentiate them. TE, telogen effluvium, shock loss, which is what a lot of people probably have when they present to their physician. Post-baby, post-surgery, COVID, you know, anything can really cause telogen effluvium, even after a transplant. And then excessive hair pulling, your traction alopecia, your trichotillomania. Okay, so if you look at a few non-scarring examples, you see some alopecia areata on the left, all right? So that, I put this up here purposely because usually the alopecia areata spots are so beautifully well demarcated, and it's just like, oh, okay, yep, alopecia areata, and you kind of can go right down. But this one actually was a little tricky. The biopsy showed us that. So alopecia areata, example there, and then just on the right, that's just your classic crown, your classic male pattern baldness, all right? So there's nothing tricky going on there, all right? So when we get into male pattern, okay, and all these pictures are all of our clients, totally fine with being shown. So men are easy. 95% of the men, it's genetic, okay? It drops down to about 60% when we're talking about women, which is why we have to do more of a metabolic workup and make sure that we're not missing anything. But the men, give or take, it's usually pretty straightforward, okay? So to really understand the pathophys and what's going on, all right, it actually is much more convoluted than even just this, and there's still so much excellent active research going on there. But at the basic of it, if you have the gene, okay, if someone in your lineage has passed it down, it does not mean if it's maternal or paternal, it doesn't matter, okay? I know a lot of people say it's my mom's dad. That's a myth. That's not true either. So if we kind of look at the pathophys of what's going on, you have the testosterone being broken down by 5-alpha reductase, type 2, and then you have your increased DHT levels. You also will have subsequent increased DHT receptors as well, and that leads to miniaturization of the follicles, okay? So we kind of, this is where the hair world, we're like, it's such a paradoxical idea as well, because yeah, when men go through puberty, you really kind of expect the opposite. They have thick hair everywhere else. They have their pubic hair, their axillary hair, they have their chest hair. Everything's getting the exact opposite. So why do we have this, basically this paradoxical effect of the DHT receptors and how sensitive they are in our hair follicles on the scalp? So that's a very high point of research. We talk about it all the time, but that's really kind of what we're going on now. Safe donor region, I'll mention again when I talk about transplants, but it's important to know, you know, why do you see men, or some women, but mostly men, who are totally bald on top but still have that ring around? Well, it's because the hair that's considered to be in our safe donor region, which is just a term that we coined to talk about where it's safe to transplant from, is the hair that's in the back of our head, in between our ears, sometimes a little bit above our ears as well, and then you have to see if they start thinning down below. But it's really that section in the back where you see guys who still have hair there, where the hair is basically programmed to never fall out, okay? It is resistant to the effects of the DHT. It's not gonna be as sensitive. Therefore, wherever I take this hair and wherever I transplant it, assuming that your scalp is healthy and there's nothing that's gonna attack it, then that hair is gonna stay there forever. And if you have ever any desire to get into the hair world, and I'll bring you on in and come to our fun international hair meetings, there are people from all over the world doing the most fantastic and interesting research. I mean, they'll walk around with hairs coming out of their hands. They're like, look, show me. And I'm like, okay, good job. Thank you. So they're doing great research, but they don't care. They'll prove anything. So that's why we tell people the only 100% way to really get your hair back is a hair transplant. And that's assuming that, again, there's nothing going on at the scalp level. Okay. So we speak, you know, doctor language, Norwood, all right? Now, when I talk to people, the one I really care about when I'm changing kind of a treatment plan is when they get to 4, okay? Once you start to have some vertex involvement, then it's a whole different game plan, because if the patient wants like a transplant or a procedure, then once you get into the vertex, because our head is a dome shaped, I mean, the number of grafts that I'm gonna use to maybe bring down someone's bitemporal recession peaks, say I use 1,500 grafts to, you know, kind of bring their hair down and give them a nice natural hairline, I can't get away with the same coverage up here on my crown because it kind of goes down. So once they get that vertex involvement, it's a little bit of a different game, and you have to be more realistic, and how old are they and how much more thinning are they going to have. So that's the basic. And then let's just real quick talk about females. All right, so females, like I mentioned, About 60% is really going to be genetic, but you're looking about 40% is going to be another reason. So these are usually the women who have already been seen by their family doc, they've already been seen by their derm, and they've maybe been on minoxidil or something, you know, chill, but nothing like really like good yet, and like kind of the weird things that we do that aren't really necessarily FDA approved for hair yet. And so this is classic. I probably see this 5 or 6 times a day. My women, their hair has just been kind of flat, it's strawy, it's thin, it's just blah, okay? Women typically, the classic is just right on top, they're wide in part, and it's boom, all right? And they have a little bit of crown involvement, and it's more global. It's more just all over thin, whereas the men, you're typically getting that bitemporal recession. It's gonna come back to a peak and then really get that vertex. So women, we talk about Ludwig scale, okay? 1, 2, and 3, a little more, you know, but that's basically what we kind of talk about. All right, so alopecia areata, just kind of wanted to give a little bit, I know you guys already all know this, but I like to mention it as far as my hair perspective. Like I mentioned, okay, this does kind of mimic LPP, so it can be a little confusing, but for, as you can see here, which are CD8 and our CD4 cells, the difference is that in alopecia areata, they're down near the dermal papillae, where the matrix is, okay? So they can have your inflammatory response, but they're not actually having any full-on destruction, where they're so fibrotic that it can't grow up. So then versus LPP, which we'll see in a later slide, is attacking the isthmus, okay? So the normal one, so alopecia areata, that's down at the matrix, and then when we move up to the isthmus, where our stem cells are, and where it's called the stem cell bulge, where our rector pili muscle is and the sebaceous gland, that's gonna be where it's being attacked in LPP, which is, and I'll show you, which is why you can't really grow. All right, a few examples of alopecia areata, okay? The bottom right, it's probably a Kenalog injection. Oh, sorry, I thought you needed. What's that? Oh, go ahead, yeah.
Sorry, guys, I have to interrupt this. Amanda was just informed we're looking for a Lawrence Neustatter. Is there a Lawrence Neustatter in this room?
Yes.
Can you go see Amanda? Thank you. Sorry.
That's okay. Let's get back to hair. Okay. So TE, real simple. I'm going to kind of blow through these because I want to also get touch base. But you know, TE, you can give them some oral supplementation. That's always going to resolve within 6 months. Okay. They no reason. Traction alopecia. You know, these are my clients right here. So you can see how how far back they pull. And this is just from their whole life. They're pulling back. They're pulling their braids back. And for this is a nice nothing but a transplant will take this down. She could either get a little bit of a hairline lowering, but I mean, no injections. No topical, no oral, no laser therapy is going to bring that back. That has to be a transplant. She has to understand that that's the reality of it. Secondary causes, your thyroid, your lupus, your syphilis, all the other things that are going to be worked up. Okay. And then treatment. All right, so the treatments for the general man or woman who comes in with hair loss without anything else going on. All right, your topical therapies, okay? Your minoxidil, we prefer kind of the 5% for both men and women. The foam tends to do a little bit better than the solution. Your finasteride, typically remember the finasteride can fall through lower PSA, so if you're worried about that or family history, go ahead and get that measured. If people, that's your world, if you guys are still measuring those PSAs to track. Finasteride, and then dutasteride is basically a little stronger than finasteride. It's not FDA approved in America yet, it's overseas. Ashton Kutcher went on some late show and told everyone he's on dutasteride, and it was a whole big thing. And it's basically dutasteride blocks an additional receptor of the DHT receptors on our hair. So if a guy is on finasteride for his whole life and he starts to like plateau off, maybe not his whole life, maybe like 10 or 15 years, like I'm plateauing, I bump them up to dutasteride, and they tend to do well. Okay. Nutritional oral supplementation, there's a whole bunch on the market right now. Biotin is good, but I would really recommend something a little bit stronger like the Viviscal or the Nutrafol, something that kind of attacks it from different angles. Your low-level laser therapy, there's a whole ton of these on the market. Honestly, if you can get it over the internet, I kind of say I don't really know if it's strong enough. There's only one that's FDA approved. If that's something you guys are interested in talking about, you can come grab me. Injections, I do both PRP with ACell, I should mention, which I think is super important. And then exosomes, I do a lot of research with exosomes, and I work with a company in particular, but we focus on bone marrow-derived exosomes, which is right now we're getting our FDA approval, so hopefully that should happen in the next month or two. And then our hair transplants, okay? I tend to kind of just say procedures now, because I feel like transplant, they still have this Frankenstein vision of what it is, and it couldn't be further from the truth. It's a very chill day. We start at 7 a.m. If I'm doing FUE, that stands for follicular unit excision, so that's where I'm going in one by one, and I'm taking out every single follicular unit. And every time you take a follicular unit out, it could have 1, 2, 3, 4, or 5 hairs. And then we give it to our techs, and then they cut it up under a microscope. We take off some of the adipose tissue. We make sure there's no transections in the actual follicle itself. I measure how long it is. We put it in a medium, usually our PRP. That's when you have to check all these scientific stuff, right? That's when it can't be out of a body for a certain amount of time. That's when we have it in the right medium. And then we go ahead, and I'm doing a full block on the scalp. And then the whole rest of the day is I am then making all of those incisions exactly where we're going to place every single hair. We have to kind of do it single now. So the old school, you would hear plugs. Well, plugs was 20 follicular units pushed together. Now our follicular units are cut up into singles. That's why it's just so much more natural. We can feather it in your temple region, in your hairline, and it's beautiful. If I'm doing your crown and you don't really have much donor back there, like you're already starting to thin, then we're not going to cut it up into ones. I'm going to keep them in maybe your 4s and 5s because it doesn't need to look perfect. I just need coverage back there, okay? So transplants are obviously I'm not a pusher. I kind of like to let people say, if we can't get you there non-surgically, then that's what it is. I mean, so you have to, I feel them out, but that is really the only 100% for sure way. And FUT, this stands for follicular unit transplantation. That's the one that, is more old school, but it's still done by majority of hair surgeons as well. And that's where you're gonna actually cut the back of the scalp kind of in a 1-inch margin, and then you're cutting it up under the microscope as well. And you're just suturing that up. A lot of people don't want that anymore because you can get a bit of a scar in the back, and if you don't want to be able to tell, that's why they prefer, the 1x1. Everyone's different. And then alopecia areata, usually Kenalog, or they're being seen with, or you can do PRP for that as well. All right, and then scarring, let's quickly go through this, and I'll just show you some pictures as well. Like I mentioned, this is when you have inflammation actually leading to the destruction of the hair follicles, which basically can lead to irreversible hair loss. I mean, there's no way it can actually grow through the fibrosis anymore. So externally, burns, fungal infection, things like that, and then you have all your autoimmune conditions, okay? Radiation, tumors, and then you have some cellulitis and folliculitis going on down there, okay? So LPP is the most popular one that we deal with, all right? If it's usually longer down the line, there's multiple other things going on. So like I mentioned, this is where the T cells are actually attacking the isthmus, and once you attack those stem cells, the follicle is, and then it actually coalesces in, you've lost your pathway, all right? So you can kind of see what's going on. You have that perifollicular erythema. The distance between the follicles gets longer. The scalp starts to look shiny, and I don't like shiny skin unless I'm resurfacing your face. So I know I don't like that. So as soon as I can tell, that's when they have to go ahead and get a biopsy. I spent 2 months actually in residency with a dermatopathologist, and I must have seen tons of these, and I will never forget. He said, please, when you go out, don't forget, if you're ever getting a biopsy and you're trying to rule out something on the scalp, they always need 2. They always need one right in the area of the activity and one more towards the edge, because they're always going to do a vertical and a horizontal cross section. He said, oftentimes they only get 1, and he's like, we really can get more. So I said, I'll do my best to always pass on your words of wisdom. So I always make sure we send 2 biopsies so we can rule out everything. And I just wanted to show you guys the difference between LPP on the left, that's right up there where you can see all those cells attacking, and then alopecia areata is just at the bottom. So that's what's going on at a molecular level. Okay, so here's an LPP I had the other day. I just like to show people. CCCA, uncommon, but I want you guys just to see these other scarring alopecias, your discoid lupus. Like I said, I just mentioned this. Okay, see, I wanted to make sure everyone remembered 2 biopsies, okay? Treatment, all right, honestly, when I'm starting to see like really multi-system going on and hair loss is just the dermatologic manifestation, I'm working with the rheumatologist. I mean, I had a guy call me the other week, he's like, I can't get in, can you order me Skyrizi? I'm like, no, that's not my realm, you need to go to someone else, that's not me. So you can't name drop medications that you want. So the one thing I want to mention here, as far as a hair perspective, if someone says, well, can I get a hair transplant if they have an autoimmune condition? Obviously, this is a big area of research in our society, but the general kind of agreement among majority of the hair surgeons, it has to be dormant. All right, what's going on has to be dormant. That typically takes a year. Sometimes people will wait at least 2 years. But if you don't have active disease within 1 or 2 years, then there's really no reason that the hair is not going to survive. So I like to make sure I won't do anyone unless they've been seen by whoever's monitoring their condition to make sure that we know what's going on. Because otherwise you're wasting their time. If I do it and it doesn't take, then I've wasted everyone's time. All right, and then the secondary scarring alopecia, just a bystander, all right? It's destroyed, infections, burns. The woman who came to me, I know, like a month ago, and she said this was just what was just killing her every day. I'm like, well, let me take care of that. You can worry about anything else you got going on in your life. I can handle this one. So that takes me about 2 to 3 hours, all right? We put new follicles in there. She's already started growing. When you do a hair procedure, the new grafts, They will start to sprout at 3 months. At 6 months, you're 70% of the way there, and then at a year out, you're fully in. So if you have significant loss, I would say most men and women will get one transplant to give you that coverage, so you're not actually seeing scalp from the front or scalp when you're just seeing someone from eye level. And then they'll, if they want, it's usually on them, they want to come back and they'll get a second one, because then we can go ahead and transplant in between the follicles that I couldn't do the first time, and that second one gives you the coverage. So it's beautiful. I love it. Okay, so real quick, talk about candidates. So this is what I wanted to show you. That's kind of where that safe donor region is. You see that gray, all right? That's where we don't have that miniaturization. Just another idea. So this is kind of where we have to shave, all right? That's pretty abrupt. That's actually not, that's my colleague's patient, but we kind of make the hair look nice, okay? So everyone does it a little differently. All right, sample of your FUT, all right? And then that'll just heal over. See that scar up there? So that's really why most people don't want to do FUT anymore. If you ever wanted to cut your hair low in the back, you kind of run that risk, all right? A few of examples. That's the top right. That's exactly what it looks like right after, okay? And then eventually over the first few days, you give them some topical antibiotic ointment, that closes right up, and then the hair grows over it, and you can't see anything. Beards, I love to do beards. Something new. You don't start med school thinking you're going to do beard transplants, but you do. So that's what we're at. So then we're here. Topicals work well for my women. You can see this is just right on top. This is that widened part. This was her topical therapy. So we actually have our own topical. We use, it is 5% minoxidil, but it also has an antifungal and a steroid in it and a few other things just to maximize absorption. This took about 6 months. All right, this was another female who came in. This took us about 9 to 12 months, I would say. The top two were recently divorced, anxiety, all stress, everything. She was just in a bad place and her hair took a big hit. So what we did with her was all the non-surgical options, okay? She did injections. We did both. Well, before I met her, she had done 1 PRP. We did 2 with me, plus an exosomes. She's on laser therapy at home. She's on oral supplementation, and she's also on her topical, okay? She does a topical as well. So she's on all of the non-surgical options, all right? Another injection. So the exosomes injections work really, really well on all of my non-Caucasian patients. It does work well on the Caucasians as well, but their hair it's a different texture, so it just really kind of thickens up beautifully. Another young female, she actually works in AC. This is just a good example of common. This is just the common woman. How do we just get more volume, more in the hair? So she does laser therapy at home. She's on oral supplementation, and she had an exosomes injection. Just some examples of injections on the left. That was like a small transplant we did on the right, and it just looks like he combed his hair, but that's just a common example of a real subtle difference, all right? A real subtle difference. Beards, we didn't do a transplant, but this is just showing you how his beard thickened up for oral supplementation. The top, that's 6 months after his transplant. That was kind of what he sent me about a few weeks ago. And the bottom is about 3 months after his injection. What time is it? Do I have even time?
You got 30 minutes.
Oh, okay, great. All right, perfect. I didn't even mean to do that half-minute mark. Okay, so that's hair, and I am going to leave time at the end just in case anybody has any hair questions. Because I love it and it's amazing and I love chatting about it. But the other thing that I love to do also is laser aesthetics, okay? So I love to do laser work. Again, it's something that kind of fell into my lap. So I just want to show you generally what the heck is going on in this laser world and everything else, so you guys can get an idea of options out there. All right, so what is laser therapy going on? I'll show you some pictures in a second, but when we're doing laser therapy, the whole goal is that we are just using light therapy to create heat to cause destruction of cells that we don't want anymore. That's called selective photothermolysis, okay? That's the medical term for it, that's what it is, but if you think about it, if you're just putting a flashlight on your hand, it starts to get hot after a while, but if it was the right wavelength, it would destroy the damaged skin cells that we don't want there anymore. And that's exactly how it works, okay? So we're using this to target all things aesthetic. You name it, that's what we do. We do a lot of people now who, instead of getting things frozen off, they're just coming and we're just kind of ablating it away so you don't have those hypopigmented spots. So, but otherwise you're thinking, what am I targeting? I'm pretty much doing things for aesthetic reasons, all skincare. The main thing that I want to get to, which I think is promising in the laser world, because people are like, oh, it's just a Band-Aid, but it's not. Actually, there's a lot of good technology coming out, and the one technology that we use, and I'll go into this, it has a beautiful study that was done at Stanford a few years ago, and it actually did biopsies of all these patients that showed that the genetic markers that were actually on our skin cells, basically 70% of them were being turned off, okay? And yeah, we're still aging, but we're aging at the skin cells in particular are not aging as quickly as they normally would if you didn't do anything at all. And this is with maybe 2 laser treatments a year, okay? It's called BBL Hero, and we will get into that in a second. So this is kind of what's out there. Fractionated versus full field resurfacing treatments. If I'm gonna just want, somebody just has all these lines and they don't want to go down the injections route, then I have what's called the magic eraser, okay? That's called the micro laser peel, and that is a full field resurfacing. Full field resurfacing versus a fractionated treatment. So here's the idea that I want you to put in your mind. If you have a big garden bed, okay, or you have your lawn, the fractionated treatments, like it sounds, you are treating a fraction of the face. So maybe I'm treating 25%, 30%, 40%. Full field, I'm treating 100%. So if you have your little garden bed, all right, and you're doing a fractionated treatment, I'm go ahead and I'm putting holes all through that garden bed. So your fertilizer is going to be healing from the bottom up and from the outside in. And you get this beautiful kind of luminosity. All those skin cells get to the surface. They all just slough off, and you'll kind of notice after a few days, all those, you know, the browns, the discoloration, the reds, all your old skin cells that are just piling on top of each other year after year. Because most people haven't done anything about it. That's what we're doing here. So the fractionated, you're aerating the lawn. Versus the full field resurfacing is you're just mowing the lawn, okay? I am just ablating away layers of skin. And so the common area for that, women who have perioral rhytids. They have those little lines around their mouth and they start to get frustrating. It's like, I don't want to put filler in there, and they're just bothersome. Well, I just get out my laser, we just do a treatment around their mouth, they're totally numb, and it flakes off after 4 to 5 days, and then it's left smooth. So that's kind of what we're thinking. The halo, if you hear about this, our one main treatment is called the halo, okay? The halo is it's the world's only dual hybrid fractionated laser, okay? So what that means is we are inputting 2 wavelengths, 2 pulses right at the same time, the 1470 and 2940. So oftentimes when people get these treatments, they'll do one treatment and then they'll come back in a week and do another, and you get results from this one, results from this one. But we said, no, that's stupid. Let's just do it all together. So this is the only treatment that can do that. It's boom, boom. So we are putting a non-ablative and an ablative pulse at the same time. Ablative, I'm actually physically impacting the skin. Non-ablative, which I'll go on the next slide, is the BBL. That's the light therapy that permeates all the way through your skin tissue and is only absorbed by the damaged skin cells. We call them chromophores, the cells that have the color in them. Okay, so the halo is what we use. That's that big kahuna treatment. Somebody wants a nice resurfacing without like a Fraxel downtime. I mean, this is maybe 5 days max, and you're not even in pain. I mean, you're just a little bit swollen the first few days, and then all the damaged skin cells is coming to the surface. It looks like little coffee grounds, like little pepper flakes, and then it just sloughs off, and it is beautiful, okay? So, mention, as far as anatomy goes, the target here is chromophore, which I want to mention because you'll see how it's different. And we do discoloration, sun damage, acne scarring, pore size, brightness, everything. This is a really great treatment if you have clients, or if you guys yourself, doesn't matter, have really bad acne scarring. We can really turn it up, and as long as the patient's okay with being swollen for like 3 to 4 days, they will have a significant reduction in acne. And it's a whole field that I never really thought I would get into this deeply, but seeing how much it's changing even the teens up to people who are still 70, and they're like, I don't want my acne scars either. We have really done some great work, and I'm so proud of our staff because it has changed people's lives, and I'm happy for it. So this is an option, okay? Which I like more than subcisions because they get messy as well. So the next one I'll talk about is the Moxie. This is something different. This is a 1927 wavelength, okay? 1927 wavelength, the target is now water. So with the difference, this is mostly going to be targeting pigment and melasma. So melasma is so tricky and so hard to treat, from whether you just get it during pregnancy or whether you have it and your whole family has it and you step out in the sun for 2 seconds and you get brown and brown or brown or lipped. That's usually the common areas for women who come in. It's tough to treat. It's one of those you just have to manage it, and it's really difficult. So we have basically filled that void with our Moxie. This is for our younger patients who want a lighter resurfacing. It's not going to be as deep as our halo, but the downtime is very minimal. You can go back to work right the next day. So we love this new treatment modality to now target another area of patients for our skin. Micro laser peel, like I said, I'll show you pictures, mowing the lawn, all right? This is one of my most favorite treatments to do, okay? Because then women and men, they can stop worrying about, if they are worried about their lines or their wrinkles or whatnot, they don't have to go now, even think about that injection route. This gives them an alternative to that. This is your own body doing your own work, and that's all that it is. We are just taking away years of damage. That's all that we're doing. We're just the catalyst putting the energy in your skin. All right, and this is the heat destroys the tissue. So the micro laser peel, think of when you have a pot of boiling water and you have that steam coming up, we're heating your skin, and that steam is actually your skin. That's why we have our suction right there to pull it right on in. Okay, so the broadband light, this is kind of the main thing I'm so happy about. This is something, every single person could get 2 of these a year and your skin would be beautiful. Okay, this is so clutch. The BBL Hero is new technology, all right? Like I said, uses light therapy to induce changes to our cells, all right? Our target again is our chromophore. So we pretty much couple this treatment. This is a non-ablative laser. It only feels like a little prick wherever you have damage, all right? So I always have really bad rosacea up under my left eye. So whenever I get this, I'm like, here we go. And it's boom, boom. Yeah, it stings a little bit. But otherwise, all we're doing is what the BBL is doing. Like I said, it's the light gets penetrated through, and based on the different wavelengths that I use, which I change up during the treatment, if I'm using a 560 wavelength if I want to get reds, I'm doing 515 if I want to get browns, I'm doing the 490 if I want to get bacteria. So it kind of changes throughout the treatment, but this is a treatment that actually changes the genetic expression of your skin cells. So this is the treatment that the Stanford study was based off of, which is why even people who just want to say, I don't want to get into all that. I just want to look a little bit brighter. I just want to look a little bit, like I'm not tired, okay? Because people come in, I feel weathered. I feel like everyone asks if I'm tired. Well, what's happening is your skin is absorbing the light. Your skin absorbs the light and it gets darker. When we resurface that and all those old skin cells get sloughed off, now the light is reflecting off of it. So now when you're out in the sun or someone takes a picture, you can kind of see that nice sheen right off of your zygomatic arch. That's what we want. That's just natural. So all we're doing here is we're just putting light in your own skin to heat it up, and it gets attracted by the cells that we don't want anymore. So it's pretty common in our younger population to just keep their skin beautiful. Just keep it nice and beautiful, wear sunscreen, and I'm good. As we get older and we start having, oh man, I saw some AKs or SKs kind of hanging around, and you have some of those brown spots, then we just pick them up. They come to the surface, they get darker, and they slough off. So I'll do BBLs on faces, we do it on neck, décolleté, the chest is beautiful. People just, oh my gosh, it just clears their chest out. You don't even think you care about it until you don't have it there anymore. We do arms, we do legs, we do everything, okay? Other indications for BBL, it's not just the fun spots, all right? We do acne therapy, which is, we have our teens, we have older people, we do back, we really kill that acne. Laser hair reduction, just for Fitzpatrick types 1, 2, and 3. Skin tightening, and then make sure no history of seizures, epilepsy, active sun exposure. That's on us to do. All right, and then the other modalities, TRL, I'll show you a picture of that soon. That's like my favorite treatment in the world. This is the one that really does take off decades of sun damage. People say I look different. Yourself isn't different. You just took away all your damage. So yeah, you're a heck of a lot smoother, and you'll see that. But this is not, that's the deepest thing that we do. In the laser world, the TRL, it's total resurfacing laser. I'm doing ablation and I'm putting heat into your skin. So this is a facial nerve block. I have to go in and do a whole facial nerve block. Treatment takes about 30 minutes or so, but you're not leaving the house for a week, okay? This is one that they're mentally ready for, and everyone who comes in, I'm ready for it. This is what I want to do. I waited too long. I shouldn't have even let it get this far, and I'm ready to take over. That's what we do. So we give you some Pronox if you're really nervous, and I'll give them something to kind of chill them out. But this is, we'll show you a picture there. Clear V, different wavelength, okay? This is exactly what we use. This is like my sharpshooter that I'll use to get maybe vessels around the eyes. A lot of our Asian patients, they have a little darker under their eyes, and the reason is because there's a lot of vessels under that orbital bone right there. So we just go ahead and we get the laser, pull that skin down. I don't go in the orbital bone, it has to be right outside it, but we can do, I love doing vessels on the eyes. I can do it on the eyelids if they're okay with us putting their internal corneal shields in. Tons of legs, tons of legs, and then a lot of on the face, nose, chin, things like that. So that we love that treatment. And then we do some vaginal health. Okay, so Diva is our handpiece that we do some vaginal resurfacing. So what that is the other. If you remember the other one I talked about, there it is, the Halo. 1470 and 2940, well, that's the same as the Diva. So it's a similar treatment, but we're resurfacing the vaginal canal. As we get older, it gets longer, thinner, it gets drier, the cells get basically papery. And what this is doing is it's a laser. It takes me about 4 to 5 minutes, 360 degrees. I could change it to 180. I could do 90 if I'm just going over an episiotomy scar. I can do whatever. But what that's doing, that's helping with pain during sex, decreased lubrication, and incontinence. And we treat people from like 30 up to 75. Everyone, so this is something that you don't even think about. If there's any issues or any concerns, I'm like, no, you got to get something from your gyne. If they have no issues, can't be pregnant, can't do anything like that, you have to make sure there's nothing actually going wrong medically, so that has to be completely cleared. So I'm the only one who pretty much does these. So we love that. I'm trying to take out the status quo. So this is our 3D skin analysis I like to show people. This allows me to legitimize in objective form what we're doing with the patients. And when they come back in every 6 months, once a year, we put them back in our Vizia. We show you, yeah, this is what's going on a cellular level. And these are the 8 different parameters that we use to show you what's going on. So people come in, I say, this is like in your vital signs in the aesthetic world. I need to know, I need to see these percentages. And so this is just a screenshot of what we call a true skin age. So this is our esthetician, Gina. She's 46. But when we first started, before we did anything, her true skin age was 54. And how they decided that was the program that we use, Canfield Visia, if anyone's heard of it. They have about 250 to 300,000 other clients of her age and her demographic and her skin type, which is parameters that we put in the beginning. And then it spits out numbers, spots, your UVs, your browns, your reds, what's your bacteria, how big your pores are, everything. And then you can see her true skin age went down after we just did one treatment from 54 to 41. So she had some great clearing, and clients love seeing that. They're like, yeah, okay, I'm seeing some changes. All right, so here's going to show you some pictures now, an idea of what the heck is going on. So BBL, okay, Hero, that's what I was talking about, laser treatment. This is just a woman who had a little hole in her window, and for years the sun kept getting her in the window, and you can see that spot went out of control. So that was maybe a month after. Bottom right, just some more resurfacing. That's our Halo BBL. So I kind of like the gray at this. I kind of feel like this is like one of our melasma patients. It's real subtle, but if she goes out in the sun, her whole right cheek will just be like dark brown, and it's like kind of splotchy. She hates it. So this is Amoxi. This is what we treat with Amoxi. So this is after one treatment. She came back a month later. I just felt like that gray one. Maybe you can't appreciate it, but I did it. I just felt like you could see kind of like the tint of the melasma a little bit better than the actual shot. So these are difficult ones, all right? BBL at the top, see how much sun damage she had, and she's just so bright. It looks nice. That was 1 month after her treatment. The bottom, she had like 2 BBLs. She's a bodybuilder, so she, actually we did her whole body, but I liked her BBL results after just 2. So I'm saying you don't have to do all the crazy fun stuff, the Halo, the Moxie, all these other things I'm talking about. You could just do a nice BBL Hero, men, women, it doesn't matter how old you are, it just constantly just makes you feel bright and good. That's my opinion. All right, I liked this result. This was 1 month after her Halo BBL. She looks great. I mean, she looks great. She has no desire whatsoever for injections. She doesn't want any of that. I'm like, I hear you, sister. I agree with you. So we're just doing everything. She's on a skincare regimen at home. We make sure that she's on the right medicated skincare. You got to wear sunscreen. I mean, that's just, you have to wear sunscreen. And then this is her laser treatment, all right? So this was about a week. She looks great. She looks great. Okay, the left here, this is a combination of a few things that we did. This took us about 6 months. That's after 2 treatments up on the top, all that sun damage as well. And our goal really when we treat, like this girl on the bottom left here, I mean, this took us 9 months. So she had a lot of damage there. She's red, she has texture problems, she has pigmentation, she has dyschromia. So we did like 3 different treatments. We mixed a little bit of a BBL with this, does the coloration. We did a little bit of resurfacing, and she's on a skincare regimen. And then 9 months later. So we don't say, hey, you're coming in and you're walking out a week later somewhere different. You're in it with us for the next year. We plan out your whole year regimen when you come in. We put it on a calendar. You know what to expect. You know what you're doing at home, and you know everything. So this is like, you're committed and we're committed, but we have to meet in the middle, okay? So we do a really long initial consult where I put everyone in that 3D imaging, and then we go ahead and do the treatments. Here's that MLP that I was talking about. It kind of just smooths everything over. So that's an example of people who come in with those lines around their mouth, and what do I do about it? We just make her laser peel. So that was about 2 weeks later when she came back in, and everything's just kind of smoothed out. And I'm really not a fan of doing fillers around the mouth. You kind of get that railroad feeling if you go in those perioral lines, and then you got to come back every year. It's just, and financially, you do one of these, it's the same thing as a filler. So this is forever. TRL, this is that really deep one that I was talking about, all right. This is about a month later, so she's still a little pink, I would say. It takes about, maybe 6 to 8 weeks to be totally, but I mean, after week 1, you're just a light pink. So she's a lot of damage, and you can just see it's just smoothed out. So now all she'll do is she'll get maybe 2 BBLs a year, and that's all she'll do. Skincare regimen at home, sunscreen, BBL. Another TRL, I love this patient. She had never, this is the first time she's worn mascara. She doesn't have makeup on the right. I told her not to come. She's like, all I did was put mascara on. First time she put anything on in like 30 years. She never ever did, and I'm happy for her. So this is about a month later. She looks great. She's smooth, bright. Like I said, I love doing chests. I could probably put 1 billion of these up there. I love doing chests. All right, the top you can see that was about a month out when we did BBL Hero on her chest. And the bottom, I like to show you kind of what it looks like. Not a lot of my clients will show me day-to-day pictures, but we have the before, the day after. You can see everything's kind of coming up to the surface, and you're going to want to pick it, but you just have to let it slough off. A week, everything's kind of coming off, and then a month, it looks great. All right, so usually people will get maybe 3 treatments, and then they're good, and then it's like once a year. All right, let's just keep it rolling. Clear V, I just want to show you what that handpiece looked like. So that's the Clear V up there. Kind of has this sub-illuminator also that lets me see underneath the skin, so I can see under the surface, and then it has like a quartz cooling plate as well, so it keeps. Because the concern is that if you put this really high energy and it really gets hot under there, you're going to also damage the surrounding healthy tissue. So That's why I love this. They keeps that quartz handpiece protects all the surrounding tissue. So that's basically after one treatment. That's like maybe I think she came back 3 days later, but it just softens it. And you know, for a lot of women, that's bothersome. And then even for men, you get it. Even if you're healthy, it's genetic. You know, you could be a nurse, a teacher, and it's, you know, you guys get that. So this is another option other than sclerotherapy, okay? Sometimes people don't like sclerotherapy because it can leave you a little bit hypopigmented. Sometimes it doesn't work as well. So this is just another option. We just like to prevent other alternatives. And it's like to show you the difference as far as Clear V. That's 1064, so it's going so far down and compared to the other ones that we're not going so far down. But you can see how deep we can go. That's why it's kind of we say sharpshooter. All right, so you can see kind of the cleanup that we can do on different legs. That's a nice chill out time. So, like I said, I could probably keep talking for an hour, but I wanted to make sure I left any time if anyone has any questions. I know this is like a bit of a different field of medicine, but it's exciting, it's fun, I love it. I think it's necessary. I think it's a great alternative to just going down the surgery route, and it's something that anyone of any age, it feels better. It's a good field to be in. So, like I said, we're over here in Linwood up in Philadelphia, but if there's any questions out there about hair, yeah, go ahead.
Is this on? Yeah. Going for hair. So this is a little personal to me. My mother has been diagnosed with alopecia. I have no idea why her dermatologist has not started doing the Q6 Kenalog injections. I have no clue how to do it. Is that something that I can do in primary care, or does it really need to be done by someone with a cosmetics background or a dermatology background?
No, you can do Kenalog injections. I mean, even during my family med residency, we did them all the time. You don't have to have a derm. I mean, as long as it's the right treatment with Kenalog. If she has, you know, just female pattern hair loss, then Kenalog isn't going to do anything. So Kenalog is really only going to help if she has alopecia areata. Okay. That's really the main thing. But by all means, no, you can just do Kenalog injections, Q6, and you're just going to go right in the area. And you maybe shouldn't need to do more than 6 treatments. Usually if someone comes to me and they failed Kenalog injections, they've had like 6 or 7, they're like, it's just not doing anything. So again, you just have to make sure it's the right diagnosis. So I would get a biopsy first if it comes back as AA.
She's had the biopsy.
Oh, she's had it.
That's how we know for sure what it is.
No, you can do Kenalog injections. Yeah, I can talk to you
So
after.
how much and how deep would be the next question?
Yeah, so how about I talk to you afterwards and I actually have a printout for you. I can give that to you. Yeah, that's a good one. Yeah. Hi.
We talked yesterday.
Yeah.
Just for everybody else here, I own the Carolina Men's Clinic, so I deal with erections all day. Propecia, the finasteride, very bad product for erections. It will really destroy a man's erections. I just want people to know that ahead of time, because that's one of the problems I get when someone was put on that for an enlarged prostate or for hair loss. We can't do that if they want to have sex at the same time.
So yeah, I'm thankful that you brought that up. So the important thing to note about these studies around Propecia and male sexual side effects. So the 2 main sexual side effects that we're going to see is decreased hardness of erection and decreased libido. Of the hundreds of thousands of men who have been on oral finasteride, 0.03% have had true sexual side effects. And of that, 0.03% of those people have what's called post-finasteride syndrome. Some people said they had ringing in their ear, they had right foot foot pain, they had bellyache. So it's not, we take it seriously, it's not common, but I'm glad you brought that up. I do let my clients know this could happen. It is a really great drug for what you want, but the true incidence is 0.03%. They signed a consent and we set them on their way.
I would argue against that 0%.
I know.
It's very high.
This study, that study, what are you going to do? But thank you, I appreciate that opinion.
Sure.
You're absolutely right. Definitely something to let them know about. Yeah.
Could you comment a little further on hair restoration and PRP?
Yes. So PRP has obviously been big in the game with hair restoration. All right. It started out because Kobe was getting injected into his knees, and then it kept getting used more and more. And then obviously, just like anything else, the hair world, we're just kind of last to the party, and these treatments are just hair is a side effect. Okay. So PRP. There's 2 injections that are really hitting the market. Your platelet-rich plasma, which is where we're taking blood, we're putting it in our centrifuge, and that in and of itself is a process, okay? Different centrifuges and different systems are gonna give you different platelet concentrations. So, majority of people are using maybe Regen. There's a whole bunch of different systems, and you're getting platelet concentrations of about 2 to 3. People are getting good results with that. I will say that as far as our International Hair Society goes and all the literature that's coming out from the doctors who have been researching this is that 5 to 7x platelet concentration is really that target that you want to look for. So If you're crazy about details like I am, which as a hair doctor I feel like that's my responsibility, is to always do those little extra things, is I really am very hell-bent on having my platelets have a 5 to 7x concentration, and I also add something called A-cell. Okay, A-cell is actually used widely in wound care as well. I think my dog had surgery and they had put A-cell in there, and I was like, oh, this is great. So A-cell is a porcine-derived extracellular matrix taken from the bladder, and it has these great properties, so it kind of gives these signaling. So when I go ahead and put those platelets in, the platelets are going to go wherever the body really needs them, but I want them to stay at the hair. So when I go ahead and put those A-cell in, the A-cell and the platelets and the PRP actually work very well together, and our studies actually coming out are showing that the A-cell is just as, if not more, starting to see effective than the platelets itself. Okay, so the A-cell, if you ever look it up, it's a fine particulate. I use 100 milligrams, and then you use 50 per treatment. Okay, so that's PRP. You really would do treatment 1, month 2, and month 3 if it's their first time ever doing it, and then it's kind of like a maintenance flu shot where they're coming in once a year for that. PRP you can spread around the scalp a heck of a lot more. That's going to have your hair growing thicker, darker, and coarser. Side effects, mostly itching, but you can't wash for 24 hours. After that, you're pretty good. Microneedling is, that's an area where some people like to do it, some people don't. The idea is if you microneedle before, you're going to activate that inflammatory cascade and get an additional benefit. To each his own. And then exosomes is kind of the other option of PRP, which is a whole different lecture on itself. Go ahead.
Yeah, hi, you mentioned you use a BBL for melasma or hyperpigmentation treatments, and how does that differ from the IPL?
Yes, so the BBL, you have to be very careful with using it for melasma. I only use the BBL Hero. Hero stands for high energy rapid output. So that is allowing us, and the difference from the IPL is the amount of energy per pulse. So the IPL, similar to that when I talk about that Clear V, the sharpshooter, the IPL delivers a lot of energy, which is why it's really good for single spots. But when you put so much energy in one pulse, like I mentioned, you're also damaging the surrounding tissue. So with IPLs, we were seeing a lot of striping, a lot of boxing, a lot of hypopigmentation, and it was worsening things like melasma. With BBL Hero, high energy rapid output, we're putting in a whole bunch of more pulses than the IPL, but it's at a lower joules, a lower fluence, but we're putting in more pulses. So cumulatively, with the BBL Hero, we're able to put more energy in, which is going to give us more results. But we're putting them in at a lower energy rate, a lower fluence, to keep the side effects down of harming the other tissue from getting it too hot. But we're putting it in at boom, 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 rather than boom like that. So that's why we're getting these different, that's why we're getting the different results, and that's why you change the genetic expression of the skin cells, where you can't do that with an IPL. So it's basically the amount of energy. Okay. All right. Well, thank you so much. Yeah, you're fine. I appreciate you guys, and any questions, I'll see you after.
I just want to ask you a question.
Yeah, go ahead.
I have one question for Dr. Saltzburg, and no, it's not for helping me, but my question is more so, you had mentioned earlier in the talk about COVID hair loss for especially women. That's something that I'm seeing a lot in my practice. As a family practitioner, what would you recommend that I start them with other than essentially, I don't know, biotin maybe?
Yeah, so biotin's fine, and if people come to me on biotin, I'm like, finish it up. Finish up your biotin, but there's so many other excellent minor ingredients that you can put in something like a Nutrafol or a Viviscal, because at that point, if you can carry that in your office too. I mean, that's an option for another source of income for offices. Start them on Nutrafol. It's going to have because it has your marine collagen, it has your ashwagandha, it has your kojic acid, it has all of these other ingredients in there. So if you're having someone just come in, females, make sure you do a lab workup, which I'm happy to share our labs that we do for our females specifically. Lab workup and start them on nutritional therapy. It's really, any patient I put on Nutrafol is just coming back with this beautiful voluminization. Men and women both. That's your best bet. And if there's anything else going on, Nioxin shampoo pretty much helps everybody. So, all right. Thanks, everybody.
Thank you, Dr. Salzberg. Thank you. I'm going to probably talk to you afterwards.